So where does pneumatic retinopexy sit in the current evidence? So we've talked about the heterogeneity of the techniques. One detachment could feasibly be fixed with a pneumatic, a buccal, a vitrectomy. And what's tricky is we also have very heterogeneous and in some places patchy data, which makes it very troublesome to interpret. We actually have only got 2 decent RCTs with a pneumatic retinopexy arm. So we have the only sort of silver lining is that both of these studies have fairly common inclusion and exclusion criteria. So the pneumatic retinopexy study from Tornumby from 30 years ago and the more recent PIVOT study looked at breaks within 1 clock hour between 8 and 4. Any extent of retinal detachment was permitted. You couldn't have worse than PVRB or a frank media opacity, but it's important to note that in PIVOT, the later study, inferior breaks or lattice in attached retina were not a problem, and PVD, lens status, or bullous subretinal fluid were completely non-influential in the randomization process or recruitment. So looking at Tornumby's seminal study, this was a prospective multicenter RCT of 198 patients, and they demonstrated an advantage of pneumatic retinopexy over scleral buckling, similar primary anatomical success at around 80%, superior visual acuity for macular off cases at every time point to 2 years, and in fact pneumatic failures ultimately achieved better vision than scleral buccal successes. There was less post-op morbidity, less hospitalization, and less expense following pneumatic retinopexy. So more recently, and very briefly, the PIVOT RCT, which we carried out and published 4 years ago now. 176 patients randomized to pneumatic versus vitrectomy in a stratified fashion based on macular status. The vision following pneumatic retinopexy exceeded vitrectomy by 5 letters. The primary anatomical success was slightly lower in the pneumatic retinopexy arm, but secondary success was near 100% in both arms. And in terms of functional outcomes, failure of primary success in pneumatic retinopexy did not jeopardize the final outcome. We found that vertical metamorphopsia was more common after vitrectomy, and we found that subjective visual function for pneumatic retinopexy exceeded vitrectomy at 3 and 6 months. We looked at the outer retina, and we found that ellipsoid and external limiting membrane disruption was less common after pneumatic retinopexy, and that continuity of either layer was consistent with a 10-letter ETDRS advantage. In our session that we've just completed, we talked about outer retinal folds. These were less common after pneumatic retinopexy, and the presence of these at 1 month was consistent with worse vision to the tune of 10 letters at 12 months. Moving slightly down the evidence pyramid, this was our prospective non-randomized series of 157 patients. We were looking at retinal displacement, which was less common after pneumatic retinopexy. We found that anisoconia was worse in eyes with displacement, and that we found the amplitude of displacement correlated with vertical metamorphopsia, anisoconia, and vision. And then slipping slightly further down the evidence tree was the integrity study. This was a retrospective study of macular on and off studies. This really triangulated a line. So we found that retinal displacement less common after pneumatic retinopexy and was associated with outer retinal abnormalities, worse vision, and worse distortion. So basically what we know is that success after detachment surgery is defined by more than gross anatomical success, and it's influenced by surgical technique, for sure. So pneumatic retinopexy offers better vision than vitrectomy and buckling, and superior secondary outcomes to vitrectomy. Gross anatomical success, around 80%, but 99% secondary success. Superior outer retinal recovery and less displacement than vitrectomy. A lower complication burden than buckling and a lower cataract burden than vitrectomy. So basically, when you're presented with any of these eyes that potentially fulfill the criteria for PIVOT, we should be thinking about doing a pneumatic retinopexy, which is, of course, why we're here. Thank you. So I believe, Rajiv, are you up next?
It's Peter.
Oh,
Peter
my
Curtis.
apologies.